Great, it's 2 o'clock Eastern Standard Time. Welcome to our Cardiac College online session for today. My name is Paul O. I'm the Medical Director in the Cardiovascular Disease Prevention and Rehab Program at the University Health Network. It's nice to quotation mark see, close quote, some of you again, and maybe there are some new colleagues on the line today. Today's session is about how your heart works. We'll be discussing anatomy, physiology, as well as treatments. Just a reminder about some of the ground rules for those of you who've been with us before. These will be familiar to you. A reminder that these sessions are really provided for education only, and we would invite you to connect with your own healthcare provider if you need some specific advice about your situation, such as a change in medication dose or a new diagnostic test or different kind of treatment. But we do want you to ask your questions, please, and do so by clicking on the Q&A box in the webinar platform. We'll endeavor to answer those questions by the end of the session, but I may take the liberty of generalizing your question so that it's relevant for the entire group. By the end of this session, we hope to achieve these objectives and that you will have greater information about, one, how a healthy heart works, going through these major systems of the heart that includes a blood supply, an electrical system, valves that connect the different chambers of the heart, and the overall muscular function of the heart that allows it to pump many, many times per day. Secondly, what we can naturally then lead into what can go wrong with these various systems in the heart, and then the interventions that are used to try to correct these problems. And your own situation may be reflected as we move from 1 to 2 to 3 in the objectives. And perhaps some of you are present but have not had a specific heart issue, which is terrific. But still, the ideas on how to keep your heart healthy certainly do apply for all of us. So we can start with the question of what does the heart do? The heart we're familiar with as an organ that is about the size of your fist, and it's in the center to left part of your chest. It is a muscle that pumps blood all around the body, and each heartbeat sends oxygen-rich blood around the body so that our brains can function, our muscles can get activated and move around. All of our organ systems are working well. Our kidneys are getting blood to filter it around, and our liver, as another essential organ, gets the blood so that it can produce hormones for our body and different proteins and can extract bad things out. So lots of things that happen as the heart works well. The different components of the anatomic components of the heart. So we're showing you that the heart, and this is kind of split in cross section. The heart is in the center of the chest, and these large purple pyramids are the lungs that give us the oxygen that then is uptaken by the heart. You'll see that there are different chambers of the heart. The upper ones, we have both one on the right side of the chest and the left side of the chest. Imagine that you're looking at me facing you. So this would be my right atrium, my left atrium, right ventricle, and left ventricle. And the chambers are connected through a circulation system. The right side pumps into the lungs where oxygen is picked up from the lung spaces. And then that is returned to the left part of the heart. And then the left ventricle pumps this out through this large blood vessel called the aorta. And that's where it's spread throughout the body. So lovely, highly connected system of chambers and blood vessels for the circulatory system to work well. Now, some of us may know children or young adults where some of these connections didn't form exactly as intended. We call these inborn defects of the heart, or so-called congenital defects. And some of these individuals may go through different kinds of procedures, surgery or something else, to try to reestablish connections where they might be kind of off the map. Some of us may be also experiencing abnormalities of these chambers, the atria, the ventricle, the valves, for instance, and that's what might have landed us in hospital and into the rehab program. We'll talk about this in a little bit further detail in a moment. So we've got the anatomy down, but then also let's think further of the systems that kind of live within our heart to keep it functioning very, very well. And if we think about the systems of the heart, kind of like the way our houses might be built, the systems within the heart that include a blood supply, which is similar to our plumbing, an electrical system that is analogous to the electrical system of the heart, of the house, valves, which connect our different chambers, those atria and the ventricles. They function like the doors or the windows in our house. And then the overall pumping function of the muscles in our heart, which is like the walls that give integrity to the overall housing system. Blood supply, electrical system, the valves, the muscle pumping. So sometimes we need to call in the right kind of contractor to help us out, whether it's a plumbing issue, an electrical issue, a window door job, or we need some new walls put in place. Heart disease then manifests in these kinds of different ways, where plumbing problems then will be kind of denoted in medical sort of terms as diseases of the coronary arteries or the plumbing. We'll have problems with the electrical system, and these can be termed arrhythmias. Rhythm, I think we're all familiar with as the regular pattern of the heartbeats. A rhythm means that something's gone wrong with this and there's irregularity or too fast, too slow, these sorts of things, electrical problems of the heart. Valvular heart diseases occur when the doors or the windows get stuck, or that they develop leaks, that they just don't quite fit into the frames anymore. And some of us will have that experience of valvular heart disease, where things just don't open well or that they're leaky. And then finally, some of us might have come to the program because of diseases of the heart muscle, of the heart walls. And the medical term for that is cardiomyopathy. Cardio, I think you all recognize as representing the heart, and myo is the muscle, and pathy means something's gone wrong with it. So heart muscle problems. And you may recognize this as conditions like heart failure as the abnormality. We're into conditions of the coronary artery, where there is abnormality in the plumbing and where we might have some plaque that is building up. And this represents kind of decades of life where plaques are building inside the arteries. You'll recognize that, you know, the remedy for these sorts of things is to try to get rid of some of that plaque, much as a plumber might try to reduce a blockage. We may use medications to try to clean some of this out, like Drano for the plumber, or we might actually use tools, instruments to try to open this up and keep it open. So this is when we'll talk about angioplasty and stenting, or we might put in a new section of pipe. And that's where a coronary bypass operation might come in. When our arteries are narrowing up, this is when we might develop symptoms. And I think we've all heard this term called angina, which represents pain or discomfort, unease in the middle of the chest that may go into the arm or the jaw. And this represents a problem or that's felt when there is a mismatch of blood flow to the heart muscle itself versus what our demands are. So if we put the demands of the heart higher, like if we're trying to exercise and there's impairments of flow, that's when angina symptoms may come on. In terms of the electrical system, what we cannot see on the surface of the heart or even looking internally, but when there is mapping done of the electrical signals of the heart, folks have discovered there's actually this interesting wiring system that is underneath the heart. So like in the house, there's this main junction box that might be in the basement or somewhere else where the electrical signals tend to arise. They travel along these electrical bundles or pathways. There are places like where fuse boxes may happen, where the electrical signals are controlled, and then they transfer upwards through the rest of the house, much like you go from the junction, from the outside electrical signal through the junction box in the basement, through the wires up to the bedroom kind of idea. When this is working well, we have a nicely coordinated electrical system that travels from the upper right part of the heart through the middle down to the left and right chambers of the heart in a very coordinated way, upper and lower and upper and lower. And you can imagine that there might be problems that occur along the way when there are breaks or gaps or irregularities in these electrical cables, or if there's a short circuit that comes along and that there's an extra firing of electrical signals along this pathway. So that leads to these irregular types of heartbeats that come on that can either be too slow or too fast. Too slow means that, you know, there's been a break in our cable or there's wearing out of the junction box. Fast heartbeats come in when there's extra electrical signals that come in from different places. Heart blocks, again, represent breakages or other abnormalities that occur along the pathways. Atrial fibrillation is a very common abnormality that affects maybe 5 or 10% of people as they age and develop heart conditions. And this very specific abnormality, so you'll recognize this as atrium, meaning the upper chamber of the heart, fibrillation denoting a shivering, quivering, irregular pattern to the heartbeat where there's extra electrical signals that will come along, and some of them may go very fast down these wires of the heart and lead to fast irregular heartbeats that, you know, may be unpleasant, uncomfortable, limit exercise, but they may also lead to other problems in the heart as well. And then many people may just experience the occasional irregular skipped beat. By itself, not such a problem. There may be an extra signal that arises from the upper part of the heart. So it would be an atrial skipped beat or an atrial premature early beat, or they may arise from down below, from the ventricle, and be a ventricular early beat or premature beat. And I'll show you a little bit more of this in detail when it gets to be problematic. Heart valves, as we said, that there are different kind of windows or doors that separate our chambers. From the right atrium to the right ventricle, there is a valve called a tricuspid valve, a three-leaf valve. Between the right ventricle and the pulmonary or lung circulation, there's something called appropriately the pulmonic valve. Between the left atrium and the left ventricle, there is something called a mitral valve. And from the left ventricle into the main circulation, where the aorta lives, that is called the aortic valve. Normally, these valves kind of fit together very nicely and make a nice seal so that within every beat, blood only transfers in one direction through the heart. But you can see if the valves don't fit particularly well, if they're either too close together or too far apart, then this is when we might get leakages or difficulties in opening of our doors. And that leads to heart valve problems. And that's what's shown here. That, for instance, when this particular valve called the aortic one, this one can be problematic over time. When we're younger, when it's open, it looks like this. And when it's closed, it kind of looks like this kind of Mercedes symbol. And the three valves come very, very nicely together. For some people over time, with wear and tear and calcium deposits on this valve, that the valve leaflets might get quite stiff. And they may get stuck in this position where they don't close particularly well. So there's always some leakage. Or alternately, they may get so stiff, compare this one to this picture up here, that the valve may just not open up particularly well, and there's always some narrowing to some degree. That condition is called aortic valve stenosis. And the one where the valves might be leaky might be called valve regurgitation or insufficiency. So either case, it's not nice. The blood isn't flowing and staying where it should be in particularly a good way. And it might lead to the need to repair some of these valves or even replace them. With respect to heart muscle, we talked about heart muscle problem. Remember cardio, heart, muscle, myopathy problem. This leads to problems of pumping in the heart. And if we imagine that someone in this case has experienced a blockage, a plumbing problem that's led to problems in the heart muscle down below here. And indeed, for some people who experience heart attacks, there may be abnormalities in the heart muscle thereafter, which leads to this chamber, for instance, the left ventricle going from a nice normal streamlined size. I think we can appreciate here that the ventricle may actually stretch out and become dilated. In that case, the heart muscle is not pushing out the blood the way that it should be. And this can be quite problematic in terms of pushing blood all the way around through the body because the pump is impaired. So gosh, there are many issues that might occur, and that's typified on this slide. Now, those of you who were with us last week talking about medication issues, you will remember that this slide represents when we have a plumbing problem, when this plaque turns bad, that this atherosclerotic crescent moon, when it turns bad and we develop a plaque in the middle of our artery, this is quite problematic. But it does incite the idea that we might be able to do something about it. And we recall that we can use different kinds of medications to manage this issue, whether it's aspirin and other blood thinning drugs to manage the clot, beta blocker drugs to kind of calm down the whole system, statin drugs and other cholesterol medications to address this cholesterol plaque, and then the ACE inhibitors and the angiotensin receptor blockers, the prils and the sartans, to kind of smooth out the function of those arteries. So hopefully that helps blood flow. So we can use this combination of medications for our various populations. But we can also offer up different kinds of treatments as well in these kinds of plumbing sorts of issues. And some of you might have undergone a procedure, a percutaneous coronary intervention. Another word for this or descriptor for this is called coronary angioplasty. Angio refers to the blood vessel. Plasty means we've done something to change it. The way that it is done is by threading a catheter into the circulatory system, either from the femoral artery in the groin or in the wrist or arm, where wires can be taken up or pushed up towards the heart. The catheter is introduced into the artery down to the level of blockage. And here we're, for instance, seeing that if a wire is passed down to this point here where there's a blockage that's shown in kind of this yellow area, a balloon can be inflated to open up the narrowing from the inside out. That is a coronary angioplasty. If you want to see a video of this, you can go to the American Heart Association website, and they can show you a nice animation of what an angioplasty could look like. Here I've just grabbed a couple of screenshots that show the coronary artery here with the example of what a blockage might look like, and then passage of the wire and the balloon to squash this plaque against the wall. And then more often than not, to keep that artery open and the plaque kind of away from the middle of the artery, one can inflate up this metal stent to keep this artery propped open. So that's a nice thing of an angioplasty. And here is another stylized illustration of what that looks like with the artery wall. This example of the coronary plaque. Here's the wire in the middle, the balloon that's inflated with the stent to keep all of that open. And we reminded you last time on our medications talk that, you know, this is a lovely procedure to open this up. To keep this open over the longer term, we'll need the help of certain kinds of medications to keep the blood less sticky, to cholesterol treatments to fix this aspect of the cholesterol plaque, as well as blood pressure and other kinds of agents to keep the arteries kind of functioning in the most healthy way possible. The other approach, as we've alluded to, if there is a blockage in the artery like so, one can also imagine creating a whole new blood flow. So if we can't open up this area of blockage, or if there's a bunch of blockages in the heart, the preferred procedure might be that you see a cardiac surgeon who could take a section of vein out of the leg or an artery from inside the chest and then create this literal bypass. This is why this is called a coronary artery bypass surgery, that this new vessel will take blood directly from the aorta and then pass it through to the lower part of this artery on the heart surface. So nice bypass operations. And here, this illustration shows an example of where a vein graft might take. So if a section of vein from the leg about 10 centimeters long is taken out, then it can be grafted from the aorta down to the lower part of the blood vessel in the heart. And this is an example of how the internal mammary artery that's on the inside wall of the chest, it could be pulled off of the chest wall and then replugged in to this lower part of this blood vessel. So these would be examples of two typical graft arteries and veins that are used at the time of bypass surgery. Okay, so for the electrical problems of the heart, we described that one problem that may occur is that if the electrical kind of the native wiring sort of wears out and the electricity isn't transmitted particularly well, one approach is to actually build these new things called pacemakers and insert them into the heart. And a pacemaker consists of a battery and a mini computer inside of here that reads electrical signals from the heart. And this thing is called a lead of the pacemaker. And the lead can do two things. One, it reads electrocardiogram signals. And then if it senses that the heart is going too slow, it can actually deliver a signal that's generated from the battery in the computer down here to say, yeah, it's been too long since I've seen a heartbeat. I want you to beat now. So this is how the pacemaker function can work. And when one does an electrocardiogram tracing, you'll see here that these spikes represent beats of the heart. And before each beat of the heart, you'll see this narrow, sharp spike that's denoted by the red arrow. This is where the pacemaker is actually delivering the signal externally from the pacemaker computer and battery. So the pacemaker is taking over the action of driving the heartbeats in a nice regular fashion, because internally your own pacemakers and your own electrical system may not be functioning the way that you want it to go. A slightly more sophisticated system that builds on this concept. So here we're showing the heart and the blood vessel here, and there is the pacemaker battery computer. This is a smarter system called a Cardioverter defibrillator, meaning that we often have two wires that go to the heart, and these wires then will detect electrical signals and send them back to the computer. For a person that might have a whole bunch of abnormal heartbeats, so not just a slow heartbeat, but a bunch of irregular heartbeats, then that's when we might think about putting in this kind of system, because it's a lovely backup for very irregular heartbeats. So if someone might be prone to developing this kind of very bizarre, irregular, wide, abnormality of the electrical heart rhythm, this thing is called ventricular fibrillation, or another version of this might be called ventricular tachycardia. This is bad because the heart is going to stop any second now. What this system can do is read if that's ever going to happen. And then this large black bar represents where an electrical shock might be delivered from the computer and battery down these wires to kind of do a sharp reset. And then here, this is what lovely normal sinus rhythm looks like. So narrow beats spread wide apart. This is good. This is not good. And the way to go from very bad rhythms to good rhythms for some people is to deliver this defibrillation shock from this implantable ICD. For the valve problems, we've already said that, if the valve is too tight in particular, especially in this position of the aortic valve, so this is between the left ventricle and the aorta, that there is this possibility of replacing or repairing this valve. The newest technology involves putting in a catheter, again in the groin. This wire goes up and then is placed across this valve. There is a balloon that is inflated, much like the coronary artery procedure, but in this case, there's actually a valve that's put into place right at the level of the aortic artery. And it can be done either from the groin, directly punctured into the aorta, or directly punctured through the tip of the heart itself. The net effect of this is shown in these cartoons, where there's the wire, and then there's the balloon with the valve that's placed. And then when all of this is removed, you'll see that this new valve goes in place to replace this old dysfunctional valve. It almost looks like a crown that's put in here. So these transcatheter aortic valve implants or replacements, so they're called TAVIs or TAVRs. This is a popular new way of replacing this valve in place that then allows improved flow of blood across the valve and better functioning and delivery of oxygenated blood throughout. That's transcatheter aortic valves. And of course, there are still times when a surgical implant of a valve is needed. So here what we're showing you is exposure of the heart, an incision made at the level of the aorta, exposure of this abnormal valve here that looks like it's just got a lot of buildup of material so that it doesn't open or close particularly well. Here, there is a surgical procedure where that old valve is actually removed entirely. And then in the middle, this new valve is being sewn into place with a whole bunch of new stitches that pull it into place very tightly. And then this new valve is sitting very nicely. To do this kind of procedure requires opening of the chest, exposure of the heart to put one of these things in directly. And depending on how the valve looks, your native valve, and what else is going on with the heart itself, the surgeon and the cardiologist will meet together as a team to decide which procedure, either the surgical one or this transcatheter one, would be best in that particular scenario. And then finally, for conditions that might affect the heart muscle, the so-called cardiomyopathy, we don't have really great surgical approaches to this right now, but there have been major advances in using medications to help the heart that's there work that much better. And we can do this in certain ways. So if we imagine we're trying to help this pump that's struggling work a little bit better, well, we've learned that these sorts of approaches will help it out. So for instance, if the heart is struggling because it's had a previous heart attack and is kind of larger, expanded and struggling, well, one approach is simply to slow it down. And if you slow it down, that allows the heart to fill better and contract better. So medications that we've actually talked about before, the beta blockers, the ones that end in LOL, are ones that can help us out in this way, to slow it down, help it feel better, and then allow it to do its work in a much more kind of calm way. We can also think about the stress in these blood vessels, and we can think about medications like the ACE inhibitors and angiotensin receptor blockers, ones that we talked about in the medication section, the Prils or the sartans, as ways of relaxing blood vessel. Because remember that stuff called angiotensin that makes blood vessels squeeze down? We don't like that stuff, and we don't like it if our hearts aren't functioning very well. So relax those blood vessels, and that allows the system to work much better. And then finally, we may make use of diuretic medications or water pills to take water and salt out of our system and reduce fluid overload. All of these approaches have been shown to reduce the risk of hospitalization, improve the performance of the heart, and improve longevity for people that might be living with heart failure conditions. So we're using combinations of these medications as much as possible to help in that situation of heart failure or cardiomyopathy. And then I suppose in very advanced situations that some people may be living with something called a left ventricular assist device. So if the pump becomes so impaired that the medications by themselves are not doing the trick, then it is possible to put in an assist for the pump that would involve this sort of device that actually gets implanted onto the surface and internally into the ventricle to keep the blood flowing and moving along. This requires a substantial battery to keep driving this motor. So folks will carry around batteries all the time and need to be on kind of a recharge of these batteries kind of throughout the day. So that is one more advanced. Okay, we've covered a lot of territory in the last 30 minutes, and I'd love to throw this open to the group to see if there might be any questions that any of you might have about the heart, kind of normal functioning, abnormalities in the physiology or anatomy, and any interventions that might come up. Okay, I'm looking at the Q&A section. I don't see that any of you have posed any questions at this point. I'll give you a minute to kind of walk that through. And in the meanwhile, I'll also then share a little bit about other places that you can go within our education platform called Cardiac College. If you ever needed a refresher on any of this, if you wanted to learn anything more about the aspects of heart disease or diagnosing heart disease, we didn't talk very much about the diagnostic tests, but there is some great information there, as well as further information about heart procedures and heart medication. So that's available on the website. I see that there is one question that's been entered and another one again. So one is about when a stent is inserted into the artery, is the plaque itself removed? And that's a great question. And in most situations, the plaque is actually not removed. And that's why I use the sort of colloquial language that the plaque is actually squashed against the walls and held against the walls by the stent. There are occasions, but it's not done for most situations, because the stenting procedure actually works quite well for most people. There are situations where you can try to remove the plaque, and it's almost like you can use a roto-rooter that would spin around and actually cut out some of that plaque. While it sounds like that's a great idea to try to get rid of some of the stuff, you can imagine that the procedure itself it may lead to its own kinds of challenges. And if you're spinning a blade inside your artery or something like that, you may actually cause it has the potential to cause some damage to the artery wall. So it's not something that we do kind of routinely. Then the second part of the question is, in addition to the stent being placed where that single blockage is, what if there are other blockages in the arteries that might not receive a stent. So some of us, if you've had an angiogram, will have said, okay, the 90% blockage, for instance, was treated with an angioplasty and a stent procedure, but you may have heard that there was another blockage of 40% or 50% somewhere else. And your cardiologist might have said, we're going to leave that one alone and use medications. And indeed, that is the role of the medical therapies, as well as following a great diet and not smoking and exercise regularly and managing stress, because those are the therapies that will help the rest of the arteries and the rest of those blockages actually improve. So stenting is one part, the rest of the interventions go hand in hand. And if you've had one of these procedures, then I think you've had, you're asking the great question that when should you have a checkup or follow-up? And, usually your cardiologist or surgeon will want to see you a few months after the intervention, and then often at a year after the intervention to check up on how things are going. How do you know it's going well? Well, point number one is how you are feeling. So if you're in the rehab program and you're doing your walks or other activities on a regular basis, and you don't have chest discomfort and you don't have shortness of breath, those are the best signs of all. Some cardiologists may opt to have you undergo a stress test or some other kind of procedure to just see how things are going. And that can be provide some added information. But most of us would say, if you are feeling well, that's probably the best test of all. Okay, question number 2 is one related to the valve kind of procedure. And one question is, why would one have that open kind of procedure with exposure of the heart and then implantation of that valve versus having the balloon procedure with the catheter? And sometimes age may be a consideration. Sometimes it's the anatomy of the heart, just like how the valve is situated. And sometimes it's whether you need something else done at the same time. So for some people who may be older, who have difficult blood vessels to get the catheters around, the best thing might be to actually go in and pull that heart valve out completely through an open heart procedure, and then implant a brand new valve into that space that will function for the next 10 plus years without needing any new replacements. So it is a durable procedure that can last a long time and will give a better kind of replacement, because you can take out all the bad stuff and put in something good. Some people also need, in addition to the valve replacement, a bypass of one or more blood vessels. So that can be done at the time of the open heart surgery as well. So you can do the 2-for-1 kind of thing at that time. And if indeed you had one of these surgical procedures with the open chest and the open heart, then they will typically take out the old valve completely, put in the new one, and get the right size of the new one in. Okay, so I hope that answers that question that was posed. And then finally, the last question is about some durability, for instance, especially if you've had a coronary stent placed in. Is it possible for that stent to need something else? And the answer is yes, that rarely, or the vast minority of people might run into some kind of problem with that specific stent. And it's possible that if we gave you no medications whatsoever, we talked in our medication session that there's a risk of developing a blood clot inside that stent. That risk is reduced dramatically if we take aspirin plus other kinds of medications like clopidogrel or ticagrelor, or a blood thinner medication of another sort. So blood clots might be one reason that that stent gets into trouble, in which case there might need to be an additional procedure that's done. That's clotting. Another issue that might occur is scarring. Um, uh, or restenosis is the medical term that's used for it. So re means, again, stenosis is narrowing. And for some people, either within the stent itself or at the edges of the stent, it's possible that scar tissue may form and grow over time that leads to narrowing. And you may know this because of symptoms that you may experience, like chest pain coming back, or shortness of breath coming on that wasn't there before, or your exercise capacity really going down. That may lead to things like stress testing and another angiogram to detect that something has happened like that. If it happens and they discover this kind of narrowing, then yes, another stenting or another angioplasty and stenting procedure can be done. It's possible to put a stent within a stent, or another stent at the edges of where the old one was. Um, um, but again, it's the minority of people that will run into this kind of issue. How many stents can one person get? Well, some people have a single stent in a single lesion, and that's maybe all that they get. At the extreme, some people have undergone multiple procedures on many blood vessels in the heart and may end up with 5 or 6 or 7 or 8 different stents over time. So it can be quite variable in terms of the outcome, but most people, let's try to be reassuring, most people will do well with their initial procedure, and that initial stent will do very well over the long term. That's many, many, many years, with the proviso that we can help that stent work better by doing all the wonderful things that you do within your rehab program, like eat well, exercise regularly, not smoke, manage psychosocial stressors, take your medications over the long term. So they work really well hand in hand. So thanks very much for asking those questions. And I'll just round out this section and let you go. Actually, one more question comes in. Does the formation of scar tissue apply to valve replacement procedures too? And how will the cardiologist know if it's scar or the original problem of calcification? So yes, there is wear and tear that can occur on valves. And this is why people may need a second valve procedure. And this is why that, if a younger person, like at the age of 30 or 40, needed a valve, they might anticipate what the second or the third operation might be over time, and use that in decision making of the kind of valve and the kind of procedure. Is it possible to tell if this is kind of scar tissue or calcium that might occur from that? And sometimes the kinds of imaging that one does can give you clues on what's going on with those valves. And this is why we use imaging procedures like the echocardiogram or ultrasound of the heart, in addition to other types of imaging like CT scans that can pick up calcium particularly well. Okay. So I will round this out and let you go. That again, at the Cardiac College website, and you've seen these materials, and we'll ask you to refer to them again, that there are these lovely booklets that talk about how your heart works, and the common tests and treatments. Those are very nicely developed. And then finally, here's what we've done today, and I appreciate that a number of you have joined us for today's session. How does your heart work, and what happens when it doesn't was what we covered off today. And we've presented that there are sources of information about your heart, and hopefully you'll feel in a slightly better position to ask your physician, healthcare provider, nurse practitioner questions about your heart. We thank you for your attention and invite you to join us again So next week, in the evening, we're trying out an evening session to see if that might be more convenient for some people considering work schedules. We're going to turn to the important topic of diabetes medications, and especially their relevance not only to glucose control or sugar control, but also relevance to heart health. So please do join us next week if you have the time and the interest. Thanks very much for participating. Have a great day, and we'll look forward to connecting again at Cardiac College Online. Thanks very much.